Just wanted to spend a little bit of time first explaining who Carilion Clinic is. I'm not sure how many people are familiar with Carilion. We're a group of 600 physicians, 8 hospitals, also like many of the other panelists, a very large employer. We employ 11,300 employees, which is the largest employer west of Richmond. We see 50,000 patients in our hospitals every year, and we're just over $1 billion company. We span really the I-81 corridor, fairly far north down into the Tazewell area, so both east and west of the I-81 corridor. Our vision is really follows the triple aim. So what we really do now is we are committed to common purpose of better patient care, better community health, and lower cost. So I want to talk just a little bit about the Affordable Care Act. There it is in all its glory, all 2,700 pages. And really there's some irony to the conversation we have going on today, because really what we've said we want to talk about is payment and delivery reform. However, there's not a whole lot in the 2,700 pages about payment reform. That does, though, provide us with an interesting opportunity, as we've heard from other panelists and other speakers today, for us to begin collaboration around payment reform. And I think that's kind of some of the excitement of innovation and creativity that this has allowed us to get into. I'm not going to go through this slide, which has been discussed many times already, although I want to bring your attention to the last 3 bullets, really. What we have found in healthcare, and we all know, is really inconsistent care, fragmentation that exists in our healthcare delivery model today, lack of coordination among all the different, whether it's an insurer, whether it's a provider, physician, hospital. There's just lack of coordination throughout. And then really our payment models are at odds with addressing the rising cost. So what all those challenges really have related to is this graphic that you can see here on your screen, which is as costs have gone up, our life expectancy really hasn't changed much, and certainly is behind many of the other developed world. So you've heard this already, healthcare value, outcomes over cost. Obviously, the best way to increase the value and the quickest way to increase value is to increase outcomes and lower cost. So there's lots of different ways we can do this. One way is we can team up with TMA or TSA and start doing all our scans there at the airport, but I don't think many people will go for that. So there's a few high-level areas that we're really focused on that we really want to get our arms around. Obviously, we need to become more efficient in our delivery system, reducing waste. We also need to get more into prevention and helping get ahead of the curve in many things. Simple things like the flu shots provide huge ways to help us lower cost. There's been much discussion earlier today about collaboration, and that's something that we've really focused on in the recent years of providers, insurers, employers, patients, all collaborating together. I want to discuss basically a case study that I wanted to share with you about our experience with congestive heart failure. As you probably are very familiar, congestive heart failure patients return to the hospital fairly frequently, to the tune of up to 30% of patients who are discharged with heart failure will come back to the hospital within 30 days for a variety of reasons. About 4 years ago, we said, you know what, that's not right. That's not where we want to be. Now, mind you, that's a tough decision for a hospital system to make. At the time, we get reimbursed the more you come to the hospital. So to go and sit in front of folks and say, you know what, we think there's a better way to take care of these patients in a lower cost environment is somewhat tricky, and it's somewhat schizophrenic. But it's something that we are committed to doing, knowing that there's a better way to care for these patients in a lower cost environment. Long story short, we opened up an outpatient heart failure clinic. We took an inpatient unit and dedicated it to specialized treatment of heart failure. We involved our primary care medical home coordinators and our home health providers, and said we need to have continuum care around heart failure. So our results took us from about where we were national average at about 25% readmission rate within 30 days to now ahead of the top 10% readmission rate, so it dropped 5 percentage points. But more importantly, in the first 2 years, we had 180 patients go through our heart failure clinic. Not a single patient was readmitted within 30 days. So now our challenge is how do we replicate this throughout our system and expand the effort so we can see more than 180 patients in that department. Some of the things that we've certainly heard a lot about that we're really focused on now is how do we risk share? How do we really risk share with employers, with insurers, and with the community so that we can align our incentives and be more aggressive in looking at payment modeling reform. It'll be interesting to note that we currently have 9 pay-for-performance agreements, and of those, we have 300 different at-risk measures, and 225 of those are unique measures. So one of the things that we're really trying to get our arms around is how can we bring insurers together with us and have some of the same measures and metrics around that, much as what we heard Len Nichols talk about earlier. Won't belabor this point. We've heard some about accountable care earlier, but this is our strategy right now. We have a Medicare strategy to look at how can we have some risk sharing with Medicare. We've got a Medicare shared savings account. And then our commercial strategy, working with Aetna and Anthem and others in order to also look at risk. And then we've really taken an effort internally in our Carilion strategy to say we've got to change our culture internally to also support accountable care. To and including hiring our chief strategy officer, who's a physician, to really help us down this journey. I want to spend a little time on population health management. Exactly what is it? This is just a high-level view of what we kind of have defined population health management as being. Very much going after a proactive, not reactive way to take care of patients. And if we were to look at a population that would be impacted by the newest guidelines being proposed for Medicaid reform and expansion by the General Assembly, we suggest that there's a population that really fits in this population health management nicely and something that would work really well. For most delivery systems, like most delivery systems, we are treating these patients now who are currently what would be uninsured patients, and a Medicaid expansion will allow us to treat these patients as a population where we can specifically align care options which will give every single patient a better plan for health. And with Medicaid expansion, we'll receive some reimbursement for that service. Now, interesting to talk about Medicaid expansion. Here, this is a Chamber of Commerce forum and a business meeting, but I think this slide here probably really impacts what you see going on in your own businesses. So over the last couple decades, what we have seen is as Medicare, Medicaid rates go down, private insurance rates, commercial insurance rates go up in order to offset that. Another way to look at that is this, what we would call the cost shifting or hidden tax graphic, and this is what a health delivery system might look like. And to orient you this real quickly, we've got the payment system there on the y-axis and the patient volume across the x-axis, and each of the payment sources coming across the middle. The red graphic is all the place where we lose money. We would lose money on an insurance rate on a payment system, with the cost line going straight across there about 3/4 of the way up. The payments from Medicare, Medicaid, and obviously self-pay not hitting even our cost level. So therefore, how do hospitals or physicians or anyone else make that up? And that's in their negotiating with commercial payers. And so the idea of getting the profit, the green area, needs to overcome or be bigger than or at least equal to the red area. So why is that important for us and maybe this discussion and as we look at payment reform and delivery reform? And I would argue that some of that really has to do with the Medicaid reform and expansion. And what I'd really like to do is conclude my remarks with this. This is really a big issue for business, and we're greatly appreciative of the efforts of the Roanoke Chamber of Commerce, the Virginia Chamber of Commerce, and other local chambers who have joined together to support Medicaid reform and expansion in Virginia. Think about it this way. When employers look to move to a region or look to expand, both the general health of the population and the availability of quality health care are factors considered by potential employers. When we improve the health of Medicaid-eligible citizens by giving them the incentive they need for prevention before they have to be treated, we are improving the general health care of our workforce. That automatically makes our region, our state, a better place to do business and more attractive place for employers. I do think that states that get this right, states that figure this piece out of how to take care of the bigger population and the workforce, is going to have an economic advantage over other states, and certainly as a country will have an economic advantage over other nations. Medicaid expansion in Virginia is not a panacea for payment reform, but it's the first best thing going to give us a huge tool in addressing the healthcare needs of a very at-risk population. Experience and data tells us that insurance coverage generally leads to improved health Experience also tells us that insurance coverage generally leads to accessing care in more appropriate venues, much like going to the physician office rather than to emergency department. Much transformation needs to occur. I think we've heard many things today about innovations in healthcare, and I would suggest that as we get into things like Medicaid reform, will also allow us to be more innovative and work closely with employers, insurers, and patients.